today is about risks and benefits of orthodontic treatment. When you do consent for your patient at the beginning of the treatment, you should discuss with your patients what are the risks and what are the benefits of orthodontic treatment, so he will be consented for this orthodontic treatment. So in this lecture, we're going to discuss these risks and benefits. We'll start with the benefits of orthodontic treatment. First one is resistant to caries and periodontal disease. So the theory that when the patient has a crowded teeth, cleaning will be much more difficult. If the patient has a straight teeth, the cleaning will be much easier. From the evidence, it showed that patients who had orthodontic treatment, they have better oral hygiene compared to the patient who did not have an orthodontic treatment. But this could be because of the behavioral changes that the patient have, not necessarily because of the teeth becoming straight. And because of that, there is no evidence to say that dental crowding is a risk for caries. As you can see in this photograph, the patient has a crowding, but look at the oral hygiene is good. So cleaning the teeth, even if it's crowded, it will be more difficult, taking more time, but it's not impossible. So orthodontic treatment mainly will not reduce the risk of caries because the patient can clean his teeth even if they are crowded, but it makes cleaning of the teeth much easier for the patient. Spend less time cleaning the teeth if they are straight compared to the crowded one. Second one, orthodontic treatment can help to prevent periodontal breakdown. As you can see in this case here, the patient has an anterior crossbite with displacement. All the forces are heavy and concentrated on this lower central incisor that will keep pushing the central incisors forward. That resulted in a gum recession. Now, this patient should be treated, and this is one of the examples of the interceptive orthodontic treatment in which it has to be treated immediately and not to defer the treatment until the permanent dentition. Other thing, if the patient has a deep, complete traumatic overbite in which the upper incisors are causing trauma to the lower or the upper is causing trauma to the palatal side, in which now orthodontic treatment here is beneficial to prevent this traumatic overbite and to correct it. Now, what about the benefit of improved masticatory effect? These came from studies like that they found that kids who has a crossbite with displacement, they have asymmetrical muscular activity during chewing, which means maybe that his muscular activity or masticatory efficiency is not as if he doesn't have a crossbite. Other thing is that patient with a class 2 or a class 3 malocclusion, maybe they will struggle during eating food. And the study has shown that these patients who has a class 2 or class 3, they improve the masticatory performance after going to the orthodontic surgery and correcting their malocclusion. So for example, with patients like this who had this negative overjet corrected into this one, his eating and masticatory effect will be improved. Don't forget that patients with anterior open bite as well, they will struggle to incise food because the teeth in the front they can't meet. And they maybe can socially embarrassed by the presenting complaint. So all of these kind of factors say that, yeah, sometimes function can be compromised by the malocclusion. However, the way we think about it that although the severe malocclusion can affect oral function, usually oral function will adapt to form well. So you can find an anterior patient with anterior open bite, but he's in a good health, he's eating properly because he adapted to this anterior open bite. Or he has a reverse overjet, so he adapted to this overjet. So it appears that malocclusion usually affect the function, but not by making it impossible, but by making it difficult. So patient has to do an extra effort to compensate for this deformity. So again, for example, patient who has a class 2 increased overjet. Now, patient might having it difficult to incise food, but he can compensate by moving, for example, the mandible forward, and he will be able to incise food and cut it. So again, malocclusion make the function more difficult, but not impossible. What about temporomandibular joint dysfunction? Now, first, what is TMD? TMD refers to a group of interrelated conditions associated with clicking, locking, and pain from the temporomandibular joint and the surrounding muscles. Now, numerous occlusal traits have been linked to the development of the sign and symptom of TMD, with orthodontic treatment have been advocated as both potential cause and cure. So how is that? First, if a patient has a malocclusion and he's not treated, then there was a claim that this malocclusion can result in TMD. On the other hand, orthodontic treatment, for example, involving extraction and retraction of the incisors, will result in limitation of the movement of the condyle that will result in a TMD in the future. All of these are theories. That's not an evidence base. So the theory is that some malocclusion can cause TMD, and the theory is as well that some orthodontic treatment will result in TMD. However, cross-sectional studies, observation of the population, have found a very weak association between certain malocclusion like crossbite with displacement, increased overjet, and a higher prevalence of TMD. A very weak connection, not a strong one. And there's no evidence to suggest that orthodontic treatment, even the one is associated with extraction, can result in a TMD. So orthodontic treatment, regardless of the mechanism or the mechanics that is used, there is no link that it can cause TMD, so it's not a risk to develop a TMD. However, there is also lack of evidence to support the concept that orthodontic intervention can reduce the signs and symptoms of TMD. So basically, orthodontic treatment neither cause nor eliminate or reduce TMD. For that reason, the American Association of Dental Research recommended that the treatment of the TMD should be based on the use of conservative and reversible treatment modality only. So you don't provide orthodontic treatment to your patient just to relieve TMD. And at the same time, you don't tell the patient that the risk of orthodontic treatment that he will develop the TMD because the evidence showed that there is no connection. What about speech? Can malocclusion cause speech problem so that orthodontic treatment will solve this problem? Now, to do here, you need to think about, to understand this point, to think about speech. When is the speech develop? Speech develop very early. The kids start talking when he's 2 years. Some of the kids start talking when they are 3 years, and they do full sentences when he is still in the primary dentition. So the speech pattern is established very early in the life, long time before the eruption of the permanent teeth. So how speech problem is connected and related to the malocclusion? So that's a weak association. However, having said all of that, certain type of malocclusion will increase certain type of speech problem. Like for example, patient with anterior open bite will have a lisp and a problem with the S sound, lisping. So these patients might benefit from orthodontic treatment. However, if you're gonna provide treatment just for a speech problem, you can't tell your patient that you can guarantee that after orthodontic treatment, he will speak properly. Because maybe the malocclusion and the anterior open bite is one factor, but there is multiple other factors that contributed to this lisping that the patient has. What about orthodontic trauma? Prevention of trauma. So if you have a patient like this with a huge overjet and incompetent lips, and he's playing football and it hit his face, first thing to be hit is his teeth. That will result in a fracture of the incisors. So basically, patients with increased overjet, more than 9 millimeter, and incompetent lip, they are at higher risk of trauma compared to patients without or with reduced overjet. And evidence has showed with a randomized clinical trial that early treatment and correction of the class 2 reduce the risk of developing trauma. So yeah, if patient has increased overjet, incompetent lips, then orthodontic treatment is beneficial to reduce the risk of trauma. What about the psychological benefits? So what happens sometimes at school, that the kid has an increased overjet. This increased overjet, for example, which is the most common kind of malocclusion that the kids get teased and bullied because. So he got teasing and bullying because of his increased overjet or because of his malocclusion. And that will affect his self-esteem. So he will have a lower self-esteem compared to the kids who does not have this malocclusion and increase in the overjet. And for that reason, if you have a kid with increased overjet that having a psychological problem, being teased and bullied, there should be a treatment provided immediately. And there's an evidence that kids who had an early treatment for class 2, they will have a better self-esteem compared to the untreated group. So yeah, there is a psychological benefit from orthodontic treatment. And also, there's a growing evidence about quality of life. Now we have the patient usually, there is an association between a poor oral health related quality of life and orthodontic treatment and malocclusion. And that orthodontic treatment provided to this patient will result in a better quality of life. So it's again here, orthodontic treatment help in improving self-esteem, help in improving quality of life. So now we are done with the risks of orthodontic treatment. We are done with the benefits of orthodontic treatment. What about the risks of orthodontic treatment? First, the risks from appliance itself. So you can see here, we can have enamel demineralization. As you can see, we have white spot lesions, as we can see on this photograph. So if we have a white spot lesions, as this one, okay, that can result in spots in the teeth. We call this enamel demineralization. So what is the etiology? Mainly poor oral hygiene. Patient is not brushing his teeth properly. That is combined with diet that is high in sugar. And remember, when we talk about sugar, we are talking here about frequency more important than quantity. So if the kid is keep eating sugar during the day, that high frequency, that will result in a higher risk of demineralization and caries. So if that's combined with poor oral hygiene, poor diet like high in sugar, that is combined by a long treatment time, these factors will result in demineralization. How to prevent these ones? Excellent oral hygiene, non-cariogenic diet, and as extra protection, ask the patient to use 0.05% sodium fluoride mouthwash on a daily basis. That is proven to reduce the risk of white spot lesion. And then the other risk is enamel fracture. So when enamel fracture is going to happen, when you take the brackets off, this is here, we call it a debonding player, and this is the bracket. So when you finish orthodontic treatment and you need to take the braces off, you simply have this debonding player blades just go into the stem of the bracket and you squeeze it, and we are hoping that the fracture will take place at the bracket base cement interface. So basically the rest of the cement will stay on the tooth, some of the cement will be on the bracket, and so the fracture will take place at the cement bracket interface. Now, back in the time when the ceramic bracket first introduced, a silane coupling agent was used to bond them, which resulted in a strong bond that when we do the debond, this bond is very strong to the point that the fracture will take place at the enamel dentine interface. So you take the bracket off and it come up with a chip of the enamel on it. However, this is very rare nowadays because all the ceramic brackets that we are using nowadays, we're using regular composite, and they increase and we don't need to use the silane coupling agent and the resulted risk of fracture of the enamel. Root resorption, external root resorption is almost universal finding for orthodontic treatment, and it's expected. However, usually this one is not clinically significant and it has no long-term effect on the health of the tooth. However, in certain cases, root resorption will be higher, as we can see here in the lower incisors, in these upper incisors. Now, if the resorption happened to more than 1/3 of the root length, that will be reported to be, that will be a severe one, and that happen in 1 to 5% of the orthodontically treated teeth. Now, usually a higher risk for root resorption happen when a higher force and a heavy force is used. So root resorption is going to happen anyway to all the patients, but it will be minimal. It will not affect the long-term survival of the tooth. However, even with following a good amount of force, light force, still 1 to 5% of the population will have a severe root resorption. This is a risk that you need to tell your patient about before you start the treatment, and to try to avoid applying heavy force, not to increase the risk of root resorption. Pain and damage to the pulp. So if you apply a heavy force that result in complete occlusion of the blood vessels, then this will result in necrosis of that tooth. So definitely with the wires nowadays, it's really hard to reach that amount of a heavy force. Usually the force is low unless you're applying really heavy force that is resulted in occlusion of the blood vessels and necrosis. Also, kicking the root outside the cortical plate of bone will result in cutting of the blood supply to the tooth. That will result in necrosis. Gingivitis as well can cause by orthodontic treatment, mainly if the patient does not brush his teeth properly. The gingiva will be inflamed and it will be enlarged. That will make it even worse because that will be more difficult to clean, and the gingivitis will increase even more. So extra careful oral hygiene should be given, instruction should be given to the patient from the beginning. There's some claims that pushing the bands to the subgingival margin or gingival margin will cause a little bit of gingival enlargement. Sometimes there's claims as well when you do space closure, the gingiva will be enlarged as well. However, the key point on the gingivitis is oral hygiene. Good oral hygiene, less chances of gingivitis and gingival enlargement. Alveolar bone loss. Now, orthodontic treatment for patient with active periodontal disease will result in abrupt bone loss. For that reason, whenever a patient is gonna go undergo orthodontic treatment, oral hygiene should be checked, periodontal status should be checked, bleeding on probing should be checked to make sure that we don't have an active periodontal disease. So for example, if you have a patient with pocket, now this pocket could be an active disease that is ongoing disease, or could be a pocket that it was there, it was treated, and now everything is fine. So you need to do periodontal consultation, or if you want in the clinic, you need to do at least probing, bleeding on probing. And if there is bleeding, that means that this pocket is still an active disease, and you should not proceed with the treatment, because any treatment on a periodontally compromised tooth with periodontitis will result in more bone resorption compared to a non-periodontal involved patient. As well, make sure not to push the teeth outside of the bone. As we mentioned now, if you overdo a non-extraction treatment, the way to provide space is to procline the upper and lower incisors. That sometimes will result in pushing the root outside the bone, as we can see here. So this is a risk of treatment if you very ambitious about non-extraction treatment and pushing the teeth outside the bone. So we have to be careful whenever we're treating a patient. Teeth should not be pushed a lot outside the bone, labially or buccally. Oral ulceration is a risk of orthodontic treatment. Definitely, that could be happened by a protruded wire. Even the brackets themselves can cause this problem, because simply the friction between the bracket and the mucosa can result in ulceration. Allergic reaction is a risk. Nickel is presented in the bracket, it's presented in the arch wire, and many patients are allergic to nickel. So if it is there, it could have a risk of intraoral allergy. Usually it appears as a reddish discoloration like gingivitis, but it is presented with a good oral hygiene. Facial aesthetic. How that is a risk for orthodontic treatment? Well, if a treatment is conducted incorrectly with extraction, that might result in dishing in of the profile worsening the patient profile. However, this facial aesthetic one, it came up in the last 20 years maybe, that extraction will result in retraction of the teeth, and then that retraction of the teeth will result in having the patient in a more retrusive profile that is not attractive profile. All right. So let's see what is the evidence and where is the cases. So first, let's see this patient first. She's complaining about protrusion. Treatment was done by extraction, retraction of the incisors. As you can see here, the teeth are over retracted to the point that the nasolabial angle become increased. Now, if you look at this patient, the patient herself is happy because she doesn't want to have this protrusion. However, this kind of little bit what happened here is kind of not make it ruin the patient profile, but kind of increase this nasolabial angle a lot. Patient now is appearing of a retrusive profile, so this is the risk we are talking about. However, extraction is not at all bad if it's done in the correct scenarios, in which, for example, like this patient, extraction and retraction, and mini screws is used to do enough amount of retraction, resulted in a significant improve in the patient protrusive and in the patient profile. So if you look at this patient here, he has a creased overjet, he has a thin lip, while this patient, she has a protrusive lips, protrusive teeth, and this patient will benefit from orthodontic treatment with extraction, while this patient, extraction and retraction will result in worsening on the patient profile, and this is exactly what we are talking about as a risk of orthodontic treatment. So in the hands of a good orthodontist, this is not considered as a risk because you're not going to do extraction in such a patient. So what the research said, the research showed that lip prominency is reduced following the extraction of 4 premolars. However, changes are small and generally considerable to be favorable, and there's also large amount of individual variation. So if you do extraction, the lip prominency will be reduced, which makes sense. However, is not in a severe amount that make the patient doesn't look good, and it's just in a right amount. Mid-arch extraction also do not lead to unacceptable narrowing of the smile and collapse in the vertical dimension. There's been claims that if you do extraction, the arch will become narrow, it will collapse, it will not gonna look nice. The evidence showed that nothing is correct. So the current evidence therefore indicate that properly planned and executed orthodontic treatment, including that one with mid-arch extraction, does not damage the facial appearance. Indeed, it's appeared to have a beneficial effect. So to summarize the patient profile and the facial aesthetic, if you do the extraction on the right time with the right patient, that will result in a better result. If you do the extraction in the correct patient, that will ruin the patient profile. Relapse is the last risk that we have for orthodontic treatment. So relapse is defined as a partial or full return of the treated malocclusion to the original one after we finish the treatment. So if patient has a crowded teeth, you align them, you finish the treatment, you debond, the teeth will be malaligned again. Now, relapse and retention will be covered in details in this upcoming lectures, but for now, we need to know that relapse is gonna happen every single patient. However, the relapse having more risk after certain type of orthodontic tooth movement compared to other orthodontic movements. For example, rotated teeth, lower incisor crowding, changes in the labiolingual position of the lower incisor, expansion of the lower intercanoid, and spacing, they have a higher risk for relapse. So when you see patient with this one of malocclusion, that means that permanent retention, long-term retention is mandatory. However, after 50 years or even more of studying retention and relapse, a Cochrane review came up with a conclusion for Simon Littlewood, that the crowding and the relapse is a multifactorial process that can be affected as well by the age-related changes. So even if you committed to the treatment mechanics, still relapse is a risk. For that reason, patient at these days, after we finish orthodontic treatment, we provide them with a lifetime retention. which means that he has to keep wearing the removable retainer for life, or at least to have a bonded retainer to make sure the teeth stay where they are. That was all for the risks and benefits of orthodontic treatment. Thank you very much for listening.